Good. Okay. Welcome. I'm Susan Brewer, the Dental Hygiene second year coordinator, and this is the 21st anniversary, 21st event for the clinical research presentations. These are presentations done by the second year students, and because of COVID, we're doing it a little different this year, but we are very flexible, and we figured out a way to make it happen and get the presentations done and get everybody their CEs. So, off we go. Thank you.
Hi, my name is Kaylin. This is Sabrina. Today we're going to be giving a presentation on manual toothbrushes versus electric toothbrushes. To start off, we gave a little background on when the first toothbrush was invented. Obviously, it was a manual toothbrush, but it said that it was invented around 700 AD, but the first noted invention was made in 1780 by William Pax. We have a picture of what these supposedly look like, and as you can see, the material was wood, something you could find just lying around, but the end was splayed to mimic bristles. I also want to point out that this shows people have been practicing oral hygiene for a long time. The first electric toothbrush was invented in 1937 by Tomlinson Mosley, but it wasn't able to be utilized until 1954. As you can see in the picture, the toothbrush has a cord which needed to be plugged into a power outlet in order for the toothbrush to work. Just looking at this screams hazard at me. But the thought for the invention was good. It was meant to help people with mobility issues and orthodontic patients. Obviously, these brushes have some differences, so we just wanted to point out some. A manual toothbrush is manipulated by you, which means you control the angles and the pressure, whereas the electric toothbrush manipulates itself. You can only just place the brush head on the tooth, and it does the angles and produces the right amount of pressure. We put a diagram of the angles you should be using when you brush, which this diagram is one that we show our patients in clinic sometimes, just to demonstrate the proper way to brush. There's also some similarities though. An electric toothbrush was made with the structure and performance of the manual toothbrush in mind, just enhanced. They both are made with different brush heads, sizes, and bristles. With the bristles, there's different textures or hardness. They range from very soft to firm. The options are according to your oral hygiene needs. The main part is they're both meant to remove plaque and debris and to help us achieve good oral hygiene. We also listed some pros and cons of the two. For both, I'm going to bring up people with limited mobility. They could either benefit or not benefit from either. It's just according to their disability and needs. Some pros of manual toothbrushes are obviously the price, which is very affordable. It can range from $1 to $3. It is also easily adaptable for someone with mobility issues. For example, putting a tennis ball on the end to help with grip and stability. The size is another pro. It makes traveling easier because it is compact. Also, if you were in a crunch and needed a toothbrush quick, you can only go to any store to buy a manual toothbrush, even a gas station. And then we put a picture of the small hand to help with stability. Now, some cons of a manual toothbrush that we listed. One of the cons that we see in clinic is toothbrush abrasion, which is due to too much pressure being applied when brushing. Also, the recommended time to brush is 2 minutes, but with manual toothbrushing, that is rarely met. So to reach the allotted 2 minutes, you either need to count or start a timer, which this could also mean people are not brushing thoroughly, and not brushing thoroughly can lead to oral issues and complications. And we'll put a picture of toothbrush abrasion. Now for some pros for the electric toothbrush. Most of the time, you just need to buy the base once and replace the brush head as needed. As I talked about earlier, the recommended time you should brush is 2 minutes. But with an electric toothbrush, there's only a built-in timer. This toothbrush will have less signs of toothbrush abrasion since it's basically doing all the work for you. One of the biggest cons is the price, which is a big deal because it ranges from $15 to $250, which is not very affordable for anyone. There's also a risk you take spending that kind of money, but most of the companies offer a warranty. And lastly, some electric toothbrushes can be hard to travel with because they are bulky, and the bulkiness could be one of the issues someone with mobility issues might have.
Okay, so the article that we chose was a comparison of efficacy of manual and powered toothbrushes in plaque control and gingival inflammation. It was conducted among the population of the East Indian region. Bacterial plaque in the proximity of the gingival margin has been emphasized to play a potential role in the pathogenesis of periodontal disease. Its role in the cause of periodontal disease has been extensively documented. Across the world, it is confirmed that deterrence and inhibition of accumulation of plaque on the surfaces of teeth result in a major breakthrough to achieve excellent periodontal health. Regular removal of supragingival plaque has been shown to reduce counts of pathogenic species, both super and subgingival. Okay, so to see which toothbrush is more effective, we chose an article that performed a randomized clinical trial over a period of 4 weeks, controlling the plaque index, the gingival index, and the oral hygiene index. The objective of this trial was to analyze and assess the effectiveness between a manual and electric toothbrush on supragingival plaque and the gingival health. The random selection consisted of 45 people ranging in the ages 18 to 25. The selection criteria of individuals for the study consisted of several things. The individuals needed to have moderate to good oral hygiene, no dental caries, no tobacco use, and only have ever used a manual toothbrush. A minimum of 20 teeth in the oral cavity, no systemic medical conditions, and no drugs taken 1 month prior to the study. The study design consisted of 2 groups. Group A had a total of 23 individuals, and they were allotted a manual toothbrush. They were asked to use the modified VAS method when brushing. Group B had a total of 22 individuals, and they were allotted an electric toothbrush. They were given instructions to hold the bristles of the toothbrush at right angles to the gingival margin or sulcus. Both groups A and B were given the same toothpaste throughout the study. The experimental design of the study was a duration of 28 days. The individuals were asked to report to the department on days 0, 7, 14, and 28 after completing oral prophylaxis. 24 hours before appointment 0, the individuals were asked to brush their teeth. On day 0, each individual was disclosed with a disclosing solution in the form of a rinse, and this gave the plaque scores for each individual before they had brushed their teeth. The gingival status and gingival bleeding was also checked for each individual. After the plaque score, gingival status, and gingival bleeding was performed, both groups were asked to brush with the toothbrush and toothpaste they were given for 2 minutes at the department. Re-examination was done after the disclosing plaque, and the plaque score was reported. Further, the individuals were instructed to use the allotted toothbrushes using the prescribed brushing techniques at home daily for 2 minutes, and were given appointments on the 7th, 14th, and 28th days. On day 7 and 28, the same investigational measures were carried out, and the PI gingival index and Russell's periodontal index were evaluated and measured like that as done on day 0. And statistically, evaluation was done. The participating individuals, whether they used manual or power toothbrushes, demonstrated a great decrease in the PI score and GI health improvements. The individuals using power toothbrushes showed a comparatively better decrease in PI scores and gingival health improvement on the 28th day. Within the limitations of this study, following conclusions were made. The PI reduction was found in individuals of group A and B from day 0 to day 28. A better significance was seen in individuals of group B when comparison was done between group A and B. Decrease in the gingival inflammation was seen in both groups, which were evaluated using the GI scores. However, no significant difference was seen statistically in the GI scores when comparison was done between group A and B. There was a statistical significance reduction in the percentage of gingival bleeding index when group B was compared to that of group A. So the results of the present study suggested that power toothbrushes have the potential to improve oral hygiene when compared with a manual toothbrush. The ability for optimal plaque removal and improving gingival health to an individual is provided by the use of power toothbrushes. Irrespective of manual dexterity of training, this confers good brushing technique on all who employ it. These are our sources. Does anyone have any questions? Thank you.
Okay, my name is Kaylee Stevens,
And I'm Anna May.
and today we're going to give a presentation about e-cigarettes and vaping and how the sugar additives in it affect the oral cavity.
So what exactly is vaping? Well, a vape uses a battery instead of a flame. The chemicals inside are heated up and then a flavor is produced. It's offered in many different flavors, really anything you can think of from fruity to minty. Vaping is more popular because of the different flavors. The chemical vapors are inhaled, and that is where the name vaping comes from. And then there's many myths that vaping isn't as bad as regular smoking, but in reality it's worse and more addictive because of the different flavors.
Okay, so now we're going to talk about how does it actually affect the oral cavity. And the vapors from the e-cigs actually form a bacteria known as Streptococcus mutans that stick to the teeth. These bacteria stay on the teeth for periods of time, especially since most people have their vape without the date, and it's so easy to access and easy to carry. And the bacteria can lead to several things such as decay, cavities, and gum disease such as gingivitis and periodontitis. There's a main ingredient inside the e-cigs known as propylene glycol, and it can cause something called dry mouth. And xerostomia can lead to bad breath, sores in the mouth, and even more decay. The saliva actually neutralizes the pH inside your mouth. So when it's trying to fight against that bacteria and the dry mouth comes in, it can't fight any longer, and so the bacteria is left behind on the enamel of your teeth. Vaping can irritate the throat very badly as well. It can cause someone to feel as if they have a chronic sore throat.
So this is a picture of the 7 effects of vaping, and there's many more. These are just like the main 7. So it reduces the enamel hardness by 27%. It affects the periodontal ligament fibroblast regenerative potential. It increases the risk for xerostomia and halitosis. It increases microbial adhesion. It increases the risk of periodontal disease. It increases oral Candida albicans garage. Patients may exhibit signs of burns, irritation, and stomatitis, which is just a painful swelling and sores inside the oral cavity. And so, as you can tell, it's not good because there's not anything on this chart that says decreases, it all increases. So, can vaping cause oral cancer? That's really not exactly known yet. There are some cancer-causing agents in the vaping, or within the flavors and the chemicals and stuff, but scientists are still studying this, and they're also studying like if a person only uses a vape for a short period of time or a long period of time. So the aerosols do contain cancer-causing agents, but the risk is definitely lower than it is with regular cigarettes. That's why so many people get the idea that vaping isn't as bad as regular cigarettes because it doesn't cause oral cancer, but in reality, the oral cavity is more destroyed because from the sugar aerosols, which cause decay, dry mouth, etc.
Okay, so now we're going to look at the little chart on the side, and it's actually how can you reduce your risk of oral cancer. And on this slide, it only has 6 ways, and out of the top 3 is avoid smoking. So we're going to talk about number 1 first, and it says visit your dentist very regularly. They are trained professionally to detect signs of oral cancer. And 2 is to check your mouth regularly. So when you're just at home, just look in the mirror every once in a while and make sure there's no unusual sores or lesions. And then, of course, avoid smoking and drink alcohol in moderation. And the consumption for that is like 2 times daily max. And protect the skin with sunscreen. As we always say, any type of cancer, you can get it from the sun. And we are mainly focused on the lips, so just make sure when you're getting some lip balm, make sure it has that SPF in it. And look after your teeth and mouth. Brush twice daily and floss at least 1 time daily. And actually put in some rinse every now and then. And don't delay in seeking advice. So if you see a lesion in your mouth or you see something unusual in your mouth, don't just put it to the side for a few days and let it get worse. Actually go and let a professional look at it and see what they think. And then we actually found that the research on this specific topic isn't actually known yet, but we will get there. Okay, so now we're going to talk about what does it look like. So in this first picture on the left, we see a bigger version, and it's the non-disposable type. It's battery powered and actually has a cartridge inside that holds the chemical vapors. It costs around $99 plus the additional $5 per bottle for flavor refills. The picture on the right is the most popular type. They are disposable, so you just go get them at your local gas station. They cost around $6 a piece, and it comes in about 10 flavors. These are most common in our teenage age groups because parents, sometimes they don't have these pretty labels on the outside, and sometimes parents mistake them for other things such as a flash drive and stuff, and so they don't realize their child's actually doing it. And it's a big trend in that teenage group because they think it's cool and they're not cool without it.
So the sugar aerosols in relation to caries, the flavors are offered in many different types of sugars, but the main ones are saccharides, esters, acids, or aldehydes. Esters bring on the bacteria S mutans, and then the demineralization begins and bacteria grows more and sticks to the teeth. The sugar additives increase the risk of caries, and then in this chart to the side, you can see the sugar contained in the flavors and the percent of enamel hardness lost.
Okay, now we're going to look at some detailed pictures. And the two pictures on the left, you can tell that vaping has extremely affected this person's oral cavity. And some of these effects include the inflamed gum, so you can tell it's really red, and on that bottom picture around those back teeth, you can tell it's really irritated and upset those gums. And that can lead to things like we said, gingivitis and potentially periodontitis if you don't go seek professional help. And also on the bottom, and you can also see it on the top, you can see some decay on those teeth, and that's just from those sugar aerosols sticking to your teeth. And those happen mainly in the pits and fissures of your teeth. You can also see a lot of gum recession, and that's just because the gum tissue is overall not healthy, and it's being destroyed by the vaping solutions. And then you can also see enamel wear and erosion on those front teeth especially. And also vaping and any type of cigarette smoking causes stain, and it can leave you with either a yellow, brown, or greenish tint to your teeth. That's very hard to remove. But then you get to the pictures on the right, and you see just an overall brighter smile. The gums are very healthy, firm, pink consistency, and there's no decay on those bottom teeth.
So a lot of people also think that vaping nicotine isn't included, but vaping does contain nicotine, and just like smoking, the blood vessels are constricted and the healthy cells in the oral cavity begin to die. I'm sure most of us have probably had patients in the clinic that do smoke, and you can tell they don't bleed as much, their gums are definitely not as healthy, and their gums, they're just firmer in general, but the limited blood supply to the tissues can cause recession, disease, and they're generally not as healthy. The nicotine plus the sugary flavors can kill the healthy cells in just 3 short days. And nicotine causes staining, and like Kelly said, it's usually like a yellowish brown. And then the nicotine plus the heat equals demineralization, and that is what allows the stain. So this is just a chart of vaping and the health risks and causes of death. We're going to start with deception, and so a lot of people think, like we said, it's not as bad, but in reality it's worse. And then there's a lot of profit off of it because the disposable ones are cheaper when you're buying them, but over time it adds up to be more.
Next, we're going to talk about addiction. As you can see, it's got a hazardous sign out beside it because it is very addictive. So like Anna said, it contains the nicotine still, and that's what is addictive, but it also contains all those variety of flavors, which makes it even more addictive to the younger age people.
And then tissue trauma, like we already talked about.
And then little research is done. There's not a lot of research out there about it, so people don't know the actual effects it can do to your oral cavity.
And we see a lot of underage people getting addicted to this because parents don't know what's going on. They're easy to buy. They can go to the gas station and buy them themselves if they be sneaky, or they get their older friends to buy them for them. So.
And then it's poisonous, so it puts those toxic chemicals inside your body, and every time you put the air of that in your body, it's just causing more and more damage.
And then you hear everybody say it's a trend. Everyone else is doing it, so why would I not do it too?
And last but not least is malignancies. So we've talked about how it could potentially cause oral cancer, just those sores could long-term become cancerous. And now we're going to just talk about, we just found these while researching this topic, just some examples of some patients that had started vaping. And our first example is of a young man. He tried to quit smoking, and instead he switched to e-cigarettes because he thought it was a healthier alternative. But he smoked a whole cartridge in one day. And that caused him to have very dry mouth. So to cope with this dry mouth, he just decided to take some energy drinks in. And between the two, the energy drinks plus the e-cigs, he had very bad tooth decay, enamel wear, and later tooth loss. And then the next example is of an older gentleman around 35 years of age, and he had never had a cavity before. Well, he decided to also switch to that alternative of e-cigs from traditional smoking, and within that year, his enamel began to soften and erode, increasing his risk for those cavities.
So our research was done and investigated how the sugar aerosols from the flavors affected the oral cavity as a whole. The study was repeated 3 times to make sure that it was positive and accurate. The scientists used the sampling method, and the Streptococcus mutans were exposed to the vapors that were inhaled and adhered to the tooth's enamel.
So the results we found in this research is the aerosols, those sugar aerosols we've been rambling about, actually produce an increase in microbial adhesion to the enamel of your teeth, and that exposes the flavoring aerosols. And when you expose them to the flavored aerosols, that increases the biofilm's chance to stick to the teeth, and it has a 27% decrease in enamel hardness when compared to unflavored e-cigs. The e-liquid's thickness causes the S mutants to stick on surfaces like pits and fissures. And we also found in this research that a lot of the e-cigs have the same effects and characteristics as drinking a soda. And we also found that non-flavored e-cigs is a much better alternative than the sugary ones. And then cell death from the bacteria leads to poor wound healing.
Our sources. Are there any questions?
My name is Danielle and this is Haley. Our subject is ergonomics in dentistry. Okay, so let's start with the basics. What is ergonomics? The word ergonomics comes from the Greek word ergon, which means work, and nomos, which means laws. It's essentially the laws of work or science of work. Ergonomics can be defined as an applied science concerned with the designing and arranging elements that we use in order to optimize human well-being and overall system performance. Now that we have a general understanding of what ergonomics is, we'll go ahead and jump into how ergonomics plays a vital role in dentistry. So as we know, dental work consists of physical and mental concentration and prolonged working hours that can contribute to improper working posture. While these conditions predispose dental practitioners to occupation-related diseases and disorders, the most common of them is musculoskeletal disorders known as MSDs. MSDs is basically an umbrella term for a number of injuries affecting different parts of the body that can arise from sudden exertion or making the same motions repetitively. These injuries can develop over time and they can lead to long-term disability. And according to OSHA, if you don't know what that is, it's Occupational Safety and Health Administration. They stated that work-related MSDs are among the most frequently reported causes of lost or restricted work time. And then according to the Bureau of Labor Statistics, they stated that MSD cases accounted for 33% of all worker injury and illness cases. So the problem is that dental professionals often develop musculoskeletal problems due to bad working habits, uncomfortable physical posture causing unnecessary musculoskeletal loading, discomfort, and fatigue. The solution is that when ergonomics is applied properly and correctly, this will help reduce the stress and eliminate many potential injuries and disorders associated with the overuse of muscles, bad posture, and repeated tasks. And then later, Haley will discuss ergonomic principles and how they can be applied by using a proper workstation setup, proper position with both clinician and the patient. Okay. So listed here are the dentistry work-related musculoskeletal disorders. Musculoskeletal disorders are defined as work-related disorders in the musculoskeletal system having chronic gradual onset involving muscles, tendons, ligaments, joints, nerves, cartilages, and spinal disc. They are also known as cumulative trauma disorders or repetitive motion injuries. So the neck, back, and shoulder disorders can be a cause of awkward postures from obtaining better views of the intraoral cavity. I'm not going to go through this entire list, but I will highlight most of them. Cervical spondylosis is typically age-related from wear and tear just of the spinal disc. Brachial plexus compression, that's a compression of the network nerves that send signals from your spinal cord to your shoulder, your arms, and your hands. And then the trapezius myalgia here, that's acute or persistent neck shoulder pain in the upper trapezius muscle. And hand and wrist disorders could be a cause of repeated motions, forceful exertions, and prolonged use of vibrating hand tools. So tendinitis is pretty common, is inflammation of the tendon. It's mostly common just from overuse. You have de Quervain's tendinosynovitis, which is swelling of the thumb tendons caused by repetitive motion. Trigger finger, that's just from when the tendon in your finger becomes inflamed. Carpal tunnel syndrome is very common too. That's numbness and tingling in the hand. It's from a pinched nerve in your wrist. Guillain syndrome is very similar to carpal tunnels. However, it involves a different nerve. And then you have Raynaud's syndrome. That's a condition in which some of the areas of the body feel numb and cool in certain circumstances, and it predominantly affects your fingertips. Because the smaller arteries that supply blood to the skin, they constrict excessively in response to cold, limiting blood supply to the affected area. Okay. Listed in this table are some of the risk factors in the dental workplace that contribute to work-related musculoskeletal disorders. Usually it's a combination of multiple risk factors rather than a single factor that contributes or causes MSD. There are also a lot of other contributing factors that are completely unrelated to dentistry that can contribute and cause MSD. I'll just list a few just to go over some, like home computer use, sports activities, increased activities involving the fingers. This could be needlework along with playing musical instruments, prolonged awkward postures at home, and use of household tools, just to name a few. And then lastly, there's additionally even more risk factors that are unrelated. It's like genetics, your age, poor nutrition, and medical condition. These can all just predispose the patient as well.
Okay, now that Danielle has established what ergonomics are and how they apply to the workplace, I'm going to discuss the signs and symptoms of musculoskeletal disorders. It's important to catch these signs and symptoms early on so you don't increase that severity and run that chance for chronic pain later on. The two most important signs and symptoms to look for, especially as a hygienist, are pain and discomfort in the back, hands, and neck. And if you do find yourself with this pain and discomfort, it's important to stop and assess this early on, recognize what's going on, and try to fix that problem immediately so you don't move on to these chronic signs like aching and fatigue, loss of strength, decreased range of motion, numbness, tingling, fatigue, or burning.
According to the CDC, musculoskeletal disorders are the cause of 70 million physician visits annually. Usually to treat MSDs, we use a combination of chemical and physical management. The chemical portion involves NSAIDs such as ibuprofen for the inflammation, pain, and discomfort. And on a case-by-case basis, if insomnia develops from there being so much pain and so much discomfort, we start looking into prescribing the sedative hypnotics such as Ambien or Lunesta to help with sleeping. Also, for the management and treatment, we have the physical management. This is the most broad range of options and also the most common. So a doctor or physician will go in and recommend physical occupational therapy. They might recommend chiropractic care, usually stretching and targeted exercise, and other forms of treatment such as osteopathic manipulation or acupuncture, etc. So now I'll clarify what proper economics for the dental hygienist include. There are many techniques such as clinician positioning, seated posture, patient positioning, and adjusting the dental equipment to the hygienist's advantage. So I'm going to, on the next few slides, explain each one of these in more detail. The first one we're going to talk about is the proper clinician positioning. The spine has 3 natural curves in it that when you're sitting in a neutral position makes an S. So that's the natural contour of a healthy spine and the goal when you're sitting in that position. So to achieve this shape, we're going to make sure certain body parts are in certain positions. The neck should be from 0 to 20 degrees, and you should never tip your head too far forward. The back is also going to be in that 0 to 20 degree range, and you want to make sure if you're leaning forward, you want to do it slightly from the hips, and make sure the torso is in line with the long axis of the body. Weight should be distributed evenly among the shoulders, and make sure it makes a horizontal line across the body. Those upper arms should hang parallel to the torso and never be abducted more than 20 degrees away from the body. The forearms should be held parallel to the floor and raised and lowered only by pivoting at the elbow joint. And the wrist should be aligned with the forearm, and the thumb side of your hand should be slightly elevated in order to really prevent those diseases that Danielle was talking about earlier, like carpal tunnel syndrome and Raynaud's disease. And it's also suggested for the dental health professional to stay away from what we call the just 5 minute or just 10 minute mindset, where you break these proper ergonomics for just 5 minutes or just 10 minutes because you think that by breaking them you can see a part of the mouth that you're working in better. This encourages frequency of this behavior and can quickly lead to multiple MSDs. So now we're going to talk about seated posture. You want to keep a neutral seated position at all times, and you want to make sure that your seat is adjusted before you see the patient and start treating them. So we don't want to do this in the middle of patient treatment. You're going to sit all the way back in the chair and make sure to adjust the seat height and seat tilt, and also that back of the chair depth and height as well. And it should make a straight line down your body. As you see, these really clean 90-degree angles is our goal. And your shoulders should remain relaxed. And you should be able to draw an imaginary straight line on the center of the spine. Another important aspect that we're going to talk about is patient positioning. We really position the patient to our advantage so that the hygienist does not have to move and strain to see a certain area that they are working on. For the maxillary arch, you want to make sure to put your patient in the supine position. And to see that mandibular arch, you want to see your patient in semi-supine position, as you can see those on the screen. Another technique that's often forgotten about by many dental healthcare professionals is adjusting that dental equipment to your advantage. So the first thing we're going to talk about is that overhead light. And when you're looking at the maxillary arch for that overhead light, you can place it directly over the oral cavity to anywhere over the neck. And for the mandibular, you want to do directly over the oral cavity only. Also, it's important to keep the instrument tray within easy reach of the hygienist or dentist so that you're not breaking the clinician positioning we talked about in the first slide of the techniques. Okay, now we're going to talk about applying preventative strategies. So a musculoskeletal disorder can not only cause physical harm, but also financial harm. According to a study in 2006 done by the U.S. National Library of Medicine, they stated that incorrect posture led to musculoskeletal disorders, which result in a reduction of productivity and a potential loss of earnings for the dental practice. This is why that dental healthcare professionals put so much money into research and developing preventative resources. So dental magnification loupes have been a huge breakthrough. They help magnify the area that you're working on, and they use a specific working distance to help you see and keep those ergonomics. They result in better posture, less hunching over, and eye strain for the hygienist and dentist. Also, there is a technique called the saddle stool or saddle seat design. It is shaped like the saddle that goes on a horse, and it helps you keep that S shape of the spine. It makes for better posture and less slouching. Also, there are some basic and easy tasks that hygienists and dental healthcare professionals can be aware of to ensure correctness of ergonomics, such as keeping your feet on the floor while working, using those correct operator time zones, such as, for example, for right-handed clinicians, 8 to 10 for surfaces towards, and 10 to 12 for surfaces away, and also just telling your patient to turn their head towards or away from you. And also more knowledge to hygienists, and really doing a teaching focus on it in school. Usually schools do a really good job of stressing the importance of proper ergonomics to hygienists, and as long as we continue to do so, it should help. Also, there was a study done by various dental professionals that proved that 2 to 3 minutes of stretching in between patients or even on lunch break could decrease discomfort by 15%. In conclusion, ergonomics are important and should not be taken lightly or overlooked, especially when it comes to the workplace. The goal of ergonomics is ensuring the well-being of employees. And dental employees perform many activities with potential to disrupt their ergonomics and develop new musculoskeletal disorders such as scaling, polishing, extraction of teeth, and more. There have been multiple studies done on ergonomics, and the results are clear. Most MSDs contribute to mental, physical, and financial strain. Applying preventative strategies are the easiest way to prevent a musculoskeletal disorder. Every dental professional should take pride in their practice and not let discomfort limit them from making an impact on smiles. Thank you.
So me and Susanna are going to go over the effects of chlorhexidine on gingival inflammation.
Okay, we're going to start by explaining what gingivitis really is. You can see right here in the conjunctivitis, and it is a reversible condition when gums become red, swollen, and diseased. So we see that a lot in patients. It is actually very common, and 50% to 90% of adults in the United States suffering from this condition. So we see it a lot in our patients here. Gingivitis leads to periodontitis, which is more severe, and that one is not reversible, and that is when there is bone loss. And severe periodontitis is the 6th most widespread disease globally.
Okay, now we're going to talk about chlorhexidine. So chlorhexidine is a broad spectrum antipsychotic. that decreases the growth of bacteria that causes gut disease. This medication is used along with regular toothbrushing and flossing to treat gingivitis. Chlorhexidine belongs to the class of drugs known as antimicrobials. It works by decreasing the amount of bacteria in the mouth, helping to reduce swelling, redness of the gums. Chlorhexidine is effective against gram-positive bacteria, gram-negative bacteria, and fungi. Chlorhexidine inactivates microorganisms with a broader spectrum and quicker kill rate than antimicrobials.
And then I'm showing you a little bit more of the chlorhexidine background. Chlorhexidine was discovered in 1946, and it was whenever they were looking for anti-malaria agents, they came across chlorhexidine, and it wasn't put into clinical practice until 1954, and that was in the United Kingdom, right, where it was found. But it wasn't introduced into the United States in the 1970s. And it was first used in the UK as a disinfectant and topical anesthetic. Chlorhexidine healthcare for commercial use. Chlorhexidine gluconate is one of the more commonly used forms of chlorhexidine salt due to its ability to dissolve in water and deliver the molecules in an effective way.
How long before you can see chlorhexidine effects? So research shows that you can see improvement in gingivitis with 4 to 6 weeks of use with regular brushing, and it can reduce the plaque buildup with 6 months of usage.
For clinical uses of chlorhexidine, it goes along with oral hygiene and professional prophylaxis. So just like it'll be prescribed to patients to be used like in between their cleanings, usually when they have signs of gingivitis and inflammation and bleeding. So just that with like regular brushing and care with the chlorhexidine should show better results. It is also used for immediate preoperative rinsing and irrigation, just really used to clean and sterilize anything in the mouth when there's like any post-oral surgery or any infection. So post-oral surgery is used to prevent any infection. It's also used with patients with jaw fixation. It's also used with mentally and physically handicapped patients since they have limited oral hygiene, like they can only do so much. The chlorhexidine is also used to prevent and maybe treat because they're more susceptible to having gingivitis or any type of oral inflammation. Also medically compromised patients because they are more predisposed to having like oral inflammation or sores or just dry mouth or anything that is caused by the medication. Also high-risk carrying patients, like current oral obstruction patients, and people with removable fixed orthodontic appliances, and then denture stomatitis, and that's when the denture causes irritation and it is used to prevent or to heal any of that redness or irritation.
So this is a picture of just the staining with chlorhexidine not due to your teeth with long usage. The stain can be removed with just a normal cleaning.
And this is the before and after of the chlorhexidine. So here you can see like how it's inflamed on that before, inflamed and red. In detail, that's probably like bothering the patient. They probably are bleeding a lot. They probably have deeper pockets. And then in the next one, you can see it's more pink, less inflammation. They probably have tighter gums and less deep pockets.
Okay, so overview of the research that we did, that was done on it. They did a washout phase where they instructed the patients to brush 2 times daily with a fluoride toothpaste and a soft pressure toothbrush. Then retain from oral hygiene for 12 hours. Then after that, they used a sterile mouth rinse and then spit into a tube where their spit was tested or assessed for the PMN5
plaque and gingivitis. Then after that, the patients are given a fluoride mouth rinse or a chlorhexidine mouth rinse and another soft bristle toothbrush. And toothpaste. And then they were instructed to brush 2 times daily and then rinse 30 seconds with 15 milliliters of the mouthwash for 2 weeks. The independent variable is the chlorhexidine mouthwash, and then the dependent variable is the gingival formation.
And then the hypothesis for this research was going to be if the test groups are treated with chlorhexidine, they can't in affect the gingival areas, then oral inflammation, gingival index, and plaque index will decrease from treatment. So they were just predicting that the gingival index, the plaque index, that was going to be checked at the end of the study was going to decrease from that chlorhexidine usage in the patients that did use it, and it was not going to change in the patients that didn't.
So the statistical analysis of this research showed a reduction of 0.2 on the GI and 0.4 on the PI after they used chlorhexidine, a 35% difference in just 1 week, a 54% difference after 2 weeks, and then the study showed statistical significance results, making the hypothesis valid and proven that chlorhexidine reduces PNN, plaque, and gingivitis in comparison to the control group, which was just a fluoridated evidence.
So for the personal conclusion that we decided on for this research was that we believe the effects of chlorhexidine mouthwash were shown in their positive impact on the inflammation and the redness. On the test groups, you can see that they both went down, one 5.4 and the other one 5.2. They followed Dr. Spearman, both gingival and plaque scores decreased from their baseline, and we think that it was correctly executed and was very professional and positive correlation with the gingival index and plaque index.
So some side effects of the chlorhexidine after usage is staining. It can become noticeable if used longer than a 4-week period. And soreness of the gums, decrease in taste sensation, xerostomia, and mouth ulcers.
And then the limitations for chlorhexidine. If you have any dental work, especially anterior fillings, like resin fillings, there is a chance of staining, and it would be permanently staining, and then you have to get them redone. So that's something that they should advise you when doing chlorhexidine. And then infections and perio. Once there's perio, there's already bone loss. It wouldn't really do much with chlorhexidine, so that's probably something that they would not want to try first, because it probably will not do anything to fix the perio once it is to like a severe stage. When it's gingivitis, then chlorhexidine would be more effective, and then chlorhexidine really wouldn't do much for perio or infection. For pregnancy, it is a Class B drug, so it's not yet studied on pregnant women, so they do not recommend it. I believe it's pregnancy, and then it's also kind of iffy with breastfeeding. It just depends on the dentist with the breastfeeding mode for it should be used or not on a breastfeeding mother. And then smoking, it's flammable, so it is not, you should always let your patient know not to use it because it is flammable. And not to be smoking after you do use it, so make sure you let them know.
Is there any questions?
Okay, hello, I'm Hannah, and I did my project on the effects of coffee staining on the permanent dentition. So it is no surprise that coffee stains your teeth, but understanding what causes this stain means that you can enjoy your coffee and still maintain those pearly whites. So what actually causes the stain? It is a combination between the dark pigment and the buildup over time. So what can we do to prevent this stain? We
we can try adding milk to our coffee to prevent the stain, because the color of your coffee is going to affect how deeply it stains your teeth. When you add milk to your coffee, it lightens the color of the drink and provides your teeth with protection from the staining acids in coffee. Milk also, if it comes from an animal like a cow or a goat, it is high in protein and binds to the organic compounds in coffee instead of attacking and staining your teeth. There are also a few other ways listed on the slide that you can prevent, such as proper brushing technique and drinking through a straw. Also, revisit how often you're drinking your coffee. It's better to have it all at once than to be sipping on it throughout the day. So, slide 2, these photos, it is showing coffee stain on natural tooth versus composite. These may look similar, but studies have shown that it's more difficult to remove coffee stain from composite than natural tooth. This is because the composite is more likely than natural tooth to pick up surface stains from foods and beverages. So why do we want to remove this stain? Well, other than aesthetics, coffee can grow bacteria in the mouth that can lead to tooth erosion, which can cause your teeth to become thin and brittle. So a research study I found conducted by Biomed Research International tested the effects of desensitizing toothpaste on natural tooth versus resin composite. They used 56 natural teeth and 56 teeth with resin composite. Each tooth was left in fresh coffee for 7 days, and then they were brushed for a period of time with 6 different desensitizing toothpaste. After 7 days, the colors of each natural tooth and composite were measured and compared to the previous color data. So the results are in. Every natural tooth and composite was compared the same way and brushed for the same length of time and recorded appropriately. It showed only that toothpaste containing melamine showed significant brightness for both teeth and composite with coffee staining involved. Stannous fluoride seemed to lead to more significant staining than any other ingredient. And I do believe that this study was done inside a mouse rather than individual teeth in a control setting. The outcomes may have been a little bit different. Okay, so now I have a video. It's an egg, and it's been sitting in coffee for a week. It's a separate study that I looked at, and they are just brushing with over-the-counter toothpaste, and you can see where there's still some stuff left behind. Tooth staining may only be on your mind after your daily cup of coffee, but now that we know what is the most effective way to remove the stain, let's talk about what your patient is most concerned about, the aesthetic. To counsel your patient about what you should do, about why you want to prevent the stain, is because coffee can cause other things such as halitosis, caries, and erosion. First, counsel them about prevention, and then recommend scaling and then some whitening. Simply put, just drink coffee in moderation. Dentists suggest no more than 2 cups a day. In addition, don't neglect brushing your teeth regularly and visiting your local dentist office twice a year. And these are my references. Are there any questions?
So I'm Madison and this is Sydney, and good morning. Today we are going to talk about alternate methods to prevent the usage of the drill during caries removal. It's no secret the dental office is not everyone's favorite place to be. Many are frightened by just the noise the drill makes. Our research presentation is on drill alternatives. Are you afraid of the drill? Three drill alternatives we are going to talk about today are air abrasion, enamel repairing gel, and laser treatment. All of these alternate methods have been proven to remove or prevent decay and also help keep patients at ease by avoiding the removal of the carious lesion through drilling. So air abrasion, what is it? Air abrasion was first introduced in the 1950s as an injection alternative by Dr. Robert Black. This method removes decay in a relatively pain-free manner with minimal loss of tooth structure. With minimal loss of tooth structure, there is a decreased risk for tooth fracture after the restoration takes place. In turn, this increases the lifespan of the restoration because it has more surface area to adhere to. So air abrasion can also be used to help the dentist find decay in caries that are smaller and harder to discover. It does this by brushing away some of the tooth structure to make decay more visible to the dentist. So how does air abrasion work? Similar to a sandblaster in that it sprays away the decayed portion of the tooth, leaving a viable and healthy amount of tooth structure for a crown restoration to be placed. One of three materials can be used for this procedure: silica, aluminum oxide, or baking soda. So these materials are used along with the handpiece and placed inside the tooth by compressed gas. Air abrasion removes the decayed portion of the tooth with minimal discomfort to the patient. This method of decay removal could potentially help with the patient's anxiety about a dental visit.
There are a few factors that affect removal from air abrasion. One of them is the air pressure of the handpiece. Another is the size of the particle being removed. The third is the actual quality of the particles. Obviously, harder particles are going to be harder to remove. And the last is the distance that the handpiece is being held from the tooth. There's a few advantages of air abrasion. You don't have to apply heat, pressure, or vibration unlike you would with a regular handpiece. There's a decreased need for anesthesia, which is great for patients that are scared of anesthetics or needles in general. It leaves more viable tooth structure left, which makes the actual restoration last longer, and it's easier to use than a standard handpiece. There's a few disadvantages to air abrasion too. A lot of patients could be sensitive to air abrasion, especially if they're sensitive to cold air. It's not effective for caries that are close to the pulp because of the sensitivity. It doesn't work on hard enamel, and you cannot use your loops because the air could actually mess up the lenses on the loops. It also can't be used for crowns, inlays, or on-plate preparations. So what can air abrasion be used for? It can be used for old composite restoration removal. It can be used for preparation of sealants and bonding. It can be used for surface stain removal and fits and fissure removals. It can also be used to discover cracks in the tooth.
So this study came out in 2019, so this is a relatively new research that doesn't have a definitive name yet. So we're going to stick to calling it enamel repairing gel. This method is a preventative measure only effective before the caries have developed. During restoration procedures, dentists must drill the tooth structure down in order to remove the caries lesion. Patients are losing tooth structure and are at an increased risk for recurrent decay should the restoration not go on correctly. So researchers conducting the study came up with a solution. Why not build up the most superficial layer of tooth structure to not give decay a chance to even begin formation? Using calcium and phosphate, ingredients to help remineralize the tooth, these researchers were able to do just that. Similar to fluoride treatment, the calcium and phosphate in the gel protects the enamel. The only difference is this gel has been proven to actually rebuild the enamel. Early experimental procedures were tested on extracted human teeth. Researchers placed the tooth in a solution created to mimic the oral cavity, and then placed the enamel repairing gel on the tooth and let it sit for 48 hours to allow the gel to work its magic. So the results were reviewed after 48 hours microscopically to show the gel had created an arrangement of calcium and phosphate very similar to that of real tooth enamel. The gel was only 3 millimeters thick, but researchers claimed the material could be reapplied to make the repaired enamel thicker if it was necessary. The key to the thin layer is that if applied in large clusters, the material would have a decreased strength. So research is currently being done on mice, and recently, UAB has begun to teach experimental treatment on patients.
And we have 2 videos for y'all to watch. The first video is actually using one of the gel alternative products, and the second video goes over UAB's new research. Both these videos, if you'll note, they're very similar to sealant placement.
The process starts with a little gel. It's a solution designed to prepare the surface to receive the resin. This has a cellophane type separator or applicator that can be slid between teeth so that it reaches the surface that is affected. Then, extruding this, you can get the gel to go in between teeth, and it will only go to the tooth affected. And after 2 minutes of application, we'll remove this and rinse it really well. After rinsing, we would use a solution that contains alcohol that helps dry the surface really well. Once it's super dry, then the system will be able to accept the resin very nicely. Then here we can start drying the alcohol. That will keep the surface very dry and very receptive to our system. The next step is to apply actually the resin. And it comes in the same type of system that we have. And with an applicator that can go in between teeth. So we'll slide it in and squeeze the resin out. And after the 3 minutes, we'll remove this and light it. And once it's dry, we are able to apply this light to set it and make it hard. Once the resin becomes hard, it becomes part of the tooth, and that way it restores the part that is missing and affected.
Our next alternative that we're going to talk about is laser treatment. And it actually uses infrared light in the handpiece instead of the drill. There's several uses for the laser. Today we're just going to focus on actual decay removal, but we did want to note what else you can use the laser treatment for. You can use it on hard tissue and soft tissue. The hard tissue is for caries prevention, bleaching, removal and curing of restorations, cavity preparation, and sensitivity. The soft tissue uses for laser are wound healing, removal of tissue, which can include a partially erected tooth or unerected, such as wisdom teeth. It can actually be used for malignancies and herpetic lesions. So how does laser treatment work? Like I said earlier, it uses infrared light on the tooth surface.
there is water in the tooth surface where the decay is at. The heat from the infrared light turns the water into water vapor. This also kills the bacteria around the tooth surface. After all the decay is removed, then the dentist or whoever's doing the restoration would place the restoration.
So some advantages for laser treatment are anesthesia is not necessary for the use of the laser. For some patients, this may be a great advantage because they may have negative side effects of the anesthetic or have allergies. Most patients have reported experiencing little to no pain after having the treatment done. A lot of people are scared of the sound the drill makes, so with laser treatment, there's hardly any noise. This allows the patient to feel comfortable and at ease in the dental chair.
There's a couple of disadvantages to using laser treatment. One of the biggest disadvantages is how expensive it is to actually place it in the dental office. Some of the lasers can cost up to about $90,000. Because of this, a lot of people don't have the equipment yet. It's still relatively new too, which kind of scares a lot of patients because they're scared of experimental treatment. This can also, it can be a long process just depending on how big the cavity is, because the laser is just, it's a small laser, so it can take a while to pinpoint the decay. It can't be used on previous restorations because previous restorations don't contain the water that's needed to turn into water vapor to remove the decay.
That concludes our presentation. Are there any questions?
I'm Madison and this is Haley, and we're going to be presenting on the regular consumption of lactobacillus reuteri containing lozenges to reduce gingivitis. So first, I'm going to go over what is lactobacillus reuteri. It is a probiotic. It is naturally found in the body already. It is in the gastrointestinal tract, the urinary tract, skin, and breast milk. And just a reminder of what a probiotic is, it is a live microorganism that brings a health benefit to the host when it's done at adequate amounts. Okay, so the probiotic function, it is usually taken to improve the digestion and restore normal flora. So like I said before, for it to bring a health benefit, it has to be done in adequate amounts. So you can get probiotics from foods such as yogurts, milk, juices, and soy beverages. Then also taking a dietary supplement of the lactobacillus reuteri. And that's what we're going to be exploring today in the two studies that we go over, is then taking a supplement of it. So some benefits that you can get from the lactobacillus reuteri is it produces antimicrobial molecules, it inhibits the colonization of pathogenic microbes, it reduces the production of pro-inflammatory cytokines, it promotes the regulatory T cell development and function, and strengthens the intestinal barrier. And these are just some of the key benefits, but it lists all of them, and some of these will play a role in reducing the gingivitis. So just like anything, when you take any medication or anything, there's always possible side effects. So one of the main ones is allergic reaction. It can be as severe as a fever and vomiting, or it can just present itself in the form of a rash and just itching. Some also possible side effects are stomach gas, bloating, cough, and chills. And then the first study that we're going to go over is, does the regular consumption of lactobacillus reuteri containing lozenges reduce pregnancy gingivitis? So the hypothesis of this study would be that the regular consumption of lactobacillus reuteri containing lozenges does reduce pregnancy gingivitis. So then I'm just going to set up the experiment for you. I'm just going to explain how the layout was. So there were many women that applied for the study, but they randomly chose 45 women that already have pregnancy gingivitis and met the criteria. The criteria was that they had to be at least 21 years old. They had to have an uneventful pregnancy up until that point. They already had to be in their third trimester, and they had to have gingival inflammation on the buccal surface of at least one of the root teeth, which they chose 16, 21, 24, 36, 41, and 44 to evaluate. So just they had to have one of the 6 teeth already have inflammation on the buccal surface. In the sampling method that was used in the research, it was a prospective parallel group, 2-arm, double-blind, placebo-controlled randomized clinical trial. And the method they used, so the gingival index and plaque index were both assessed at the beginning, and they also had blood taken. And the participants were randomly chosen. They were split into 2 groups just randomly, and they were all given lozenges. One group actually had the lactobacillus reuteri, and one group just had the placebo. And they were instructed to take lozenges twice a day up until their pregnancy. And then within 2 days of their pregnancy, the gingival index and the plaque index were assessed again, and another blood sampling was taken.
So this is just going over the results. I'm going to talk about that a little bit later also. But out of the 147 that were screened, 61 actually met the criteria. Of that, 16 of the subjects left. 9 of them were in the test group, and then 9 were in the placebo group, and 7 were in the test group. One more subject left early, just due to private reasons. 45 participants actually completed the trial, and 21 of those were in the test group, and 24 were in the placebo group. The test revealed that a test power of greater than 90%, and the GI, there was no significant difference between both of the experimental groups at the baseline. So the statistical analysis. Gingival index was used to measure the changes of inflammation, and then the group size was calculated by assuming that the mean was equal to 0.9 at the baseline, with a standard deviation of give or take 0.5. 2 times 26 study patients have been calculated just to verify that there was a difference in the reported mean of 50% between the test and placebo at the reevaluation. The Mann-Whitney U-test was performed for independent samples, since a normal distribution could not be assumed. The paired samples were analyzed by Wilks-Conn sign rank test, and the level of significance was less than or equal to 0.05. So the results, at the baseline, there was no significant differences of the 2 groups, like we said before. And then at the reevaluation, the GI of the test was drastically reduced from the baseline of the placebo group. And there was not much change between the 2 groups. Between the baseline and the reevaluation of the placebo group. And then this is just a graph kind of talking about the results. So as you can see in the first column there, that is your baseline, and between that one and your placebo, you can see that they're not much different. In the second graph, or the second line, you can tell that the end result of the test was that it was significantly greater, with a GI of less than 1. The baseline and the end of the placebo didn't change much. The slight change that's there, they don't know why it changed. They did a couple of tests, but it was inconclusive. So we see that the lactobacillus reuteri is good for pregnancy gingivitis, but is it good for just anybody? So they did a test of 72 healthy male sailors. They were given a 42-day supply that they were to take twice a day. 36 sailors were given the lactobacillus reuteri, and then 36 were given the placebo. Bleeding on protein, gingival index, plaque index, attachment level, and pocket depth were all assessed on days 14 and 42. At the baseline, there was no significant difference between the two groups, and the results show that lactobacillus is effective in improving and maintaining periodontal health of patients with leaking oral health, like oral hygiene.
What's a lozenge?
It's
it's like a pill or like a capsule. Cough drops are called.
Okay.
Hello, my name is Shanna,
And I'm Brittany Harris.
and today we're going to be presenting the oral health related quality of life in older adults. So first I want to start off with what is the definition of health described by the World Health Organization. As you can see, health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So for our introduction, as with any age, oral health is important. And I want to describe the oral health related quality of life definition. It's not just the objective status of oral health, but also the subjective interpretation and functional status, personal satisfaction, and emotional status of the patient. Problem and significance of study. So during the aging process, older adults obviously undergo physical, social, and psychological changes. Aging is an inevitable process of life everyone experiences themselves, with friends, and family. And as patients' age change, the needs also change, which can be overlooked by society and healthcare professionals. Over here to the right, you see we have the OHIP 14 graph. And the OHIP 14 is one of the most internationally spread oral health related quality of life indicators. It is a cross-sectional and longitudinal study based on a theoretical model developed by the World Health Organization adapted for oral health. You can see as age goes up and number of teeth go down, there is a difference in the oral health impact profile related to number of teeth and age. So for our materials and methods, we did an online database search including PubMed, Scopus, Embase, and Cochrane. We have different details of what our research concluded of and specific things that we require from each research article. Did a systematic review with meta-analysis for selecting, evaluating, and synthesizing all of the evidence, as well as a randomized controlled trial to make sure there was no certain sources of bias.
And during our research, we found a study that found over 75% of older adult patients thought that maintaining teeth had several different impacts on their overall health. We have several of those listed here on the slide, and we'll go in more depth on things such as weight, mood, chewing, oral health, and overall satisfaction. And then this study also found, or introduced the concept that teeth have a measurable positive and negative influence on the lives of older adults. Okay, so older adult patients also believe that teeth are more likely to have or improve their lives than to make them worse. We're seeing this to be true in the current generation of older adults because they say or state that the loss of teeth is less acceptable outcome than previous generations of older adults. It's also important to note that gender is going to play a role in perceived importance. So for instance, men reported to value the function of dentition to be of higher importance, whereas women reported the confidence gained of the study of pleasing dentition to be of higher importance. Then another important factor and often overlooked aspect of oral health is the impact that it can have on the psychological status of our patients. And we're seeing, now that we're switching from the traditional method of measuring oral health by objective outcomes to the oral health related quality of life model, we're seeing more data as to how this is affecting our patients' mental status. So studies have found that older adults with oral impacts are at a significantly higher risk for loneliness and depression. And then those who rated their overall health as poor were also at a higher risk of decreased morale, higher stress, and less satisfaction. So we know that indenturism, ill-fitting partials, and dentures can lead to poor eating function, difficulty speaking and communication, and emotional problems, which is going to influence the psychological distress of our patients. And then on this slide, we have a visualization of the vicious cycle of poor oral health and how, again, it can lead to low self-esteem, increased risk of depression. Important to note here as well that it leads to isolation and then overall poor psychological well-being.
And we found a study that stated isolated adults, older adults, have the lowest dental health status and utilize health services the least. So in summation, this study shows that there's a strong and consistent association between oral impacts and the psychological health of our patients. And so we know that maintaining good oral health may be a protective factor against these symptoms. Another thing that's very important to consider for each patient is their socioeconomic status. A study has found that higher socioeconomic background patients report valuing the impact on their care-free manner and social interactions, whereas lower socioeconomic backgrounds value the ability to function and mastication. This study also found that, interestingly enough, regardless of socioeconomic status, once older adults have lost more than 9 teeth, they all report the ability to maintain masticatory function as the most subjective reason they would choose to replace all missing teeth.
Okay, so edentulism and dentures. Chewing, taste perception, swallowing, and comfort with dentures has been reported to be the leading cause of poor nutritional status in our older adult population. That statistic right there is huge because we know from medication, chemo, isolation, anything, there's multiple factors that go into the nutritional status of an older adult. But comfort with dentures, chewing, taste, and swallowing is the leading cause. Xerostomia can decrease the appetite and edentulism of poor-fitting dentures. All play a major role into the inadequate nutrition of our older adult population. So for the aesthetics part of the edentulism, over 50% reported that teeth influence their attractiveness to others and the facial appearance to yourself. So it's also what you think of yourself and your confidence in that regard. Location and distribution also play a role into that. Older adult patients report that the presence of a space in the anterior region has a higher impact than the posterior region. It also reported that missing 2 adjacent teeth had a less negative effect than if they were missing several teeth spaced apart. Here's a quote from Mark Twain: "A man cannot be comfortable without his own approval." It is so important to remember that even as we get older, as we age, as different things change, older adults still value an attractive appearance, and then most believe that having a healthy dentition is a very integral part of that. So here we have a couple graphs throughout the next couple slides. N is the number of people in the study asked the question, and the percent reveals the negative effect in the study. You can see the differences between dentate and edentate. And the leading one was difficulty eating, with 16.9% with teeth and 29% not having teeth did have negative impacts on their eating. Here we have some bad effects of teeth and dentures in our older adult population. Again, N is the number of people asked in that study, and the percent is the negative effect. 30% was bleeding from chewing and biting. And then here's some of the good effects: appearance being the leading factor, and how you look to others. You feel better when you do have teeth versus not having any. And that plays into a role of kind of like the psychological status of a person. So here's the edentulism and xerostomia. Oh, sorry. Okay. So the quality of life can be compromised by a dry mouth, as it does affect mastication, swallowing, and speaking, as stated previously. Reduced saliva significantly can disturb the flow from the normal protective organisms that saliva provides for the teeth and the mucosa. Over 30% of our older adults report to have a dry mouth. Patients report significant decreases in their oral health-related quality of life when experiencing a dry mouth, like I said, as it affects mastication, swallowing, and speech. So for our decreased appetite, this is another major role in xerostomia and as our population ages. You see this cycle going down. So lack of appetite, not able to masticate properly, is a major issue with our adults. That leads to chronic diseases, psychological distress, also with side effects of medication. Diminished appetite leads to inadequate nutrition, which can also affect oral health. Our older adult patients are lacking proper vitamins, minerals, macronutrients, and then their immune system becomes impaired. Impaired immune system puts the patient at higher risk for oral disease and systemic diseases, which are linked to oral health. And this is another cycle that goes on and on with our older adult populations.
And then to continue with what Shannon is saying, we know that studies show a relationship between oral health and weight loss. So we found a recent 1-year follow-up study among adults 70 years and older that identified indenturism as an independent risk factor for unintended weight loss. Ill-fitting dentures are also a leading cause for inadequate nutrition. We know an edentulous patient's food choices are going to depend largely on the level of difficulty to masticate. So important nutritional foods such as fruits, proteins, and vegetables that can be hard to chew, the patients are now having to resort to blending these foods and turning them into a liquid diet. Well, older adult patients have said when they have to resort to that type of food intake, it can be distasteful and embarrassing, which leads to more weight loss. And this is another slide just reiterating that fact, and then some pictures of how you can imagine a patient on a liquid diet probably feels.
So in our conclusion of our study, we concluded to 3 overall factors contributing to the overall health quality of life in our older adults. 1 would be the absence of pain. 2 is the ability to maintain proper oral hygiene along with the aesthetics. And 3 is the functional ability for speech and mastication. If these 3 aspects of oral health can be maintained, dentists and hygienists can contribute to an overall positive health for our older adult population and not just dental health.
Now, we also just wanted to touch base on what our role as dental professionals can be to help better serve the elderly population. So obviously, we want to continue to focus and strive to maintain the health and integrity of our older patients' dentition. But we also want to make sure that we're using proper and effective communication, marketing, and dental counseling. In respects to marketing, studies have shown that the most effective way to market to this population is by focusing on appearance and eating function, rather than business success and sex appeal. And then with dental counseling, we should make sure that we're focused on the benefits for treatment that includes the prevention of future needed dentures, because this is a major motivating factor for older adults to try and avoid needing dentures in the future. And then lastly, we need to be aware of our patient's nutritional status and refer them out for nutritional counseling when needed. These are references. Are there any questions?